I'm really pleased now to introduce Marissa Granieri, who will be moderating the next session on designing and deploying AI tools in primary care. Marissa is a professional engineer and active patient partner within our health system, and she's one of the newest members of our OSU Board of Directors. Marissa, take away.
Thank you, Dean. Good morning, everyone, and thank you for joining us today for this exciting panel discussion. The topic, designing and deploying AI tools to address the primary care crisis. Sorry, I cannot read with these. Okay. We have a fantastic group of panelists with us, each bringing unique perspectives and expertise to the table. We will first hear from each of them individually for 5 minutes to introduce different perspectives on this topic, and then we will dive into the group discussion, and finally questions from the audience using Slido. First on our panel is Payal Agarwal. Payal is Integrated Chief Medical Informatics and Innovation Officer at Grand River and St. Mary's Hospital, and also co-leads the hospital's clinical digital strategy. We're excited to hear Payal's insight on current experience and promise of AI from the perspective of providers and patient. Please join me in welcoming Payal Agarwal.
So hi, everyone. Thanks for having me. And I have the privilege of starting off our conversation around AI and primary care. So I do work in a hospital, but I am a family doctor, and I've spent the last 10 years working on digital health and primary care. So I think something that all of us in this room are probably aware of, primary care is in a crisis, right? We know that there are millions of unattached patients, and it's only going to get worse unless we sort of intervene and find ways to support the sector and support the clinicians that provide care every day. We've heard from primary care providers that part of the reason of this crisis is administrative burden. They report over 19 hours of non-clinical administrative work weekly, which of course takes away from the joy of work and takes away from the very core activity of actually caring for patients. So, early on with some of the brilliant researchers next to me here at Women's College Hospital, we did a bit of a deep dive looking at the literature, talking to providers, trying to understand what is causing this administrative burden. And it turns out, just like many things in our healthcare system, it's a complex problem, but can generally be grouped into 3 buckets. So the first was people. We talked a lot, you hear a lot of talk about the promise of team-based care and how it can really help, to support patients and high quality care. But the reality is simply sticking people in a room together doesn't result in better care. We need to work together. We need to understand how we work together. We need division of roles. We need strong communication. We need to be able to share information. And in the absence of that, it actually leads to more administrative burden. We heard about process. We know that primary care providers want to be the quarterback of care. We work with our patients to sort of help them navigate the system, but the system is complicated. And often primary care providers are left to navigate this complex system with bad processes, making referrals multiple times, documenting multiple times, and essentially just doing a lot of low-value work. And finally, what we heard, something we're going to kind of focus in on today, is technology. Technology was supposed to make our lives better. That's what we were told. It did that in a lot of other industries and parts in our lives. But that promise never really happened in healthcare, particularly in primary care. People talked about how technology, was fragmented, had poor workflows, the burden of clicks, and really the technology, we never really realized the promise of technology working for us, working for our patients, and working to provide better high-quality care. So why is this? Again, we know to do digital technology well, if you simply take bad processes and try to digitize them, you're not going to make things better. You're probably going to make things worse. It takes time, it takes co-design, user-centered design, engagement with end users, partnerships with policymakers and vendors to get things right. So, it's a complex problem, but absolutely a problem worth solving. Sort of at the same time that we did this work, something really exciting happened. AI. There became this new technology that actually really can give us an opportunity to shift some of these paradigms in digital health. Anyone who's seen an EMR, worked in a hospital or primary care, they're essentially just large databases. They were never built to actually support clinical workflows and patient care. But with AI and this new technology, we had an opportunity to change that. So again, what we did was there was a particularly promising new AI technology called AI scribes. So for anyone that doesn't know, it's a technology that listens to a patient and a clinician while they speak, while they have their clinical interaction, and it listens and it creates a note. So for me as a provider, instead of having to look at a computer, look at a patient, go back and forth, I can just talk to you, and the technology takes care of creating my documentation. So about 2 years ago, this was actually a new but quite exciting technology. And what happened was, in recognition of the administrative burden, a couple of very key partners across the province came together and recognized that we need to get on top of this. We need to quickly come together and figure out if this technology will help and will help with the crisis that we are facing in primary care. So we had researchers from Women's College Hospital, University of Toronto, some great engineering researchers and others come together. We had digital technology partners, Ontario MD, ECE, that do a lot of work in primary care digital health, and the government. So Ministry, OH, MOH came together, and we gave ourselves a timeline of 8 months. And we said, in 8 months, can we figure out if this technology would help primary care? And it turns out we were able to. So first, we started with taking AI scribes into a simulation lab. We had an environment that looked like a primary care office. It had the EMR technology that primary care often used, and we conducted simulated patient encounters. And we had our engineers watch the screens, watch the eyes, there's cameras all around, and they then took very detailed measurements and found that AI scribes reduce the time of documentation by 70% in the simulation lab. And that is quite significant for anyone who's kind of knows, you're doing that 30 times a day. That's a quite significant reduction in documentation. But of course, that was just in a lab. Did it translate to the real world? So we partnered with Ontario MD and again, that same group, and very quickly got together 150 primary care providers across the province. And that's really important. It was not the usual suspects where we typically do research, but 150 primary care providers across the province that truly represented the diversity of primary care, geographically, payment models, all of that. And we gave them an AI scribe for 3 months to see what happened. And what we found was actually quite remarkable. So on average, primary care providers reported a 4-hour reduction in administrative burden, which is quite substantive. So that's about, definitely made quite an indent. And sort of my favorite fact, we found by far female providers benefited more from AI scribes and reported a much greater reduction in administrative burden. We had these beautiful quotes about people, being home for dinner for the first time with their family, so some very, very positive impact. And, importantly, a lot of people, we had other quotes saying, I was thinking of retiring, but with this AI scribe thing, I think I can work for another 10 years, which in the middle of a primary care crisis is a good finding, is a very positive finding. But more than that, we ended up finding a lot of other benefits that we maybe, weren't quite our top line or what we initially expected. The first was doctors reported reduced cognitive burden. I'm no longer task switching in the middle of every appointment between a computer, between pressing buttons, and between trying to pay attention to my patient and actually listen to them. I can focus on the patient. And that was huge. I can focus on them and their diagnosis. And, very happily, we heard the same thing from patients. Patients reported that their providers were much more focused on them, they felt more listened to, they felt more heard, and they left with a better patient experience. So for anyone who's done digital health research before, this is a home run. We have never had a digital technology with this so much positive feedback. So this was really, really exciting. And what was great, because this work, right from the start, we partnered with our provincial sort of policymakers and decision makers. They were able to take this work and have, very quickly been integrating it into policy. And, you're going to start to see a lot more support coming out, both provincially from our government and also federally from groups like InfoWay, around spreading and scaling these, exciting tools to primary care providers and other physicians across the province and more broadly. And, importantly, in a sort of learning health system approach, we're going to continue to be embedded in those kind of spread and scale activities and continue to evaluate, the progression and impact of these important tools. So just to, that was great. We got this, amazing piece of AI technology for primary care. But the real question is, now what? We know that AI is moving incredibly fast at an exponential rate, and there's going to be a lot more tools coming down the pipeline. Some of the things we've seen are, supporting tasks such as billing. There's a lot coming out around clinical decision support, which has a lot of promise, but of course a lot of risk as well. We've seen a lot of tools coming out around patient empowerment and how to help patients, better understand their conditions, better understand their health diseases, better navigate our healthcare system. And we see a lot of tools coming around data. Everyone knows if you've been in a clinical interaction, either as a patient or a clinician, sometimes you have too much data. And it's a textbook coming your way, and it's just not organized. It becomes very hard to understand what's important. And sometimes you don't have enough data. And that's also incredibly frustrating when you're trying to move forward with care. So, a lot of promise with AI being able to actually get the right data summarized in a way patients and clinicians can understand at the point of care. But of course, these tools have risk. They have promise, but they have risk. And the question for us now moving forward is, how do we work collectively to be able to be responsive, but rigorous in understanding which tools work, which tools provide better quality care, lead to a better, more equitable health system, and which tools are simply high risk, and how do we, if possible, mitigate those risks. So I will leave it at that and pass it on to Jay.
Thank you. Next is Jay Shaw. Jay is the Tier 2 Canada Research Chair in Responsible Health Innovation, Assistant Professor in the Department of Physical Therapy at the University of Toronto, and Adjunct Scientist at the Women's College Hospital Institute for Health System Solutions and Virtual Care. We're looking forward, Jay, to your thoughts on the ethical dimensions of AI and its implementation. Please join us in welcoming Jay Shaw.
Thank you. Thanks, Marissa, and thanks, Pyle, for that sort of overview. I think you've painted a really nice picture of the scope of issues from a practical perspective and making AI work for primary care. So really, really great starting point. And it's nice to sort of come after that and be able to sort of reflect and respond in that I approach this topic, of course, from an ethics perspective. And ethics applies to many parts of the life cycle of AI, and I do, in the work that I do, certainly see AI in primary care and healthcare from an ecosystem perspective. So design and implementation and governance, these are all really important from an ethics perspective, and they need to fit together for this to work in a sustainable way in healthcare and primary care, in Canada and elsewhere. And I mean, I also think, and I think a lot of people who do work in ethics of technology see the work that they do, ethics as an enabler. Ethics has an important role to play in pointing out things that we tend to take for granted, but it's also about, from the outset of these initiatives, identifying what it is that might be the death knell of these sort of innovation programs as well. And we've seen large, sort of high-profile instances of this in the past sort of five years or so. For example, where Ascension Health System in the United States was sharing health information with Google and had not informed their patients about that. That resulted in an enormous sort of public outcry, and that project was canned. And that's in contrast to a similar initiative between the Mayo Clinic and Google that was very well advertised and communicated to patients, which raised no issue at all. So that's a good example of how addressing ethics issues related to transparency and communication up front actually is an enormous enabler for the success of these kinds of initiatives. One other example I'll raise is something that I think tends to be overlooked as being an ethics issue, but seeing through hype in technologies and the way that they're marketed and advertised is also ethically really important. And we've seen an example of that relatively recently with the bankruptcy of Babylon Health, where it was really driven, the marketing was excellent, had a strong value proposition, had been making its way into health systems around the world, including here in Canada, and then ultimately sort of failed to live up to the promise. So addressing these issues up front from a policy and strategic perspective are really, really important. And I think people in healthcare, in primary care, get this. Like, we get this, you all get this. And I recently supported Healthcare Excellence Canada, a pan-Canadian health organization, in one of their health workforce projects, to run a subgroup on AI implementation and governance. And it was the best attended of all of their subgroups, because people realize this stuff is practical, it's important. We need to think through these ethics and governance issues at the outset of these projects. So, I think there's a lot of work to do in this domain. I think that people realize that that work involves understanding how the constituents of primary care view these technologies, our patients, the public, communities. This morning, that excellent panel talking a lot about community governance and involvement. These kinds of things I think are essential at the outset, and these are ethics issues. So I'll leave my comments here, pass it to O'Neill, and look forward to our conversation.
Thank you, Jay. Thank you. Our next panelist, O'Neill Bhattacharya. O'Neill is the director of the Institute for Health System Solutions and Virtual Care at Women's College Hospital. He is the lead for the Center for Digital Health Evaluation and the co-chair of the Canadian Primary Care Research Network. We can't wait to hear what he has to say about the potential for AI in primary care for the perspective of a health system.
Thank you. So I want to start with thanking Vasanti and Osu for their support over the years. I've been involved with the SPORE enterprise for over 10 years. And one of the things that we were keen to do at WEAVE and the Center for Digital Health Evaluation is to conduct research at the pace of policy, to be involved in the questions that policymakers had, evaluations that feed into not only the decision-making cycle around funding, but even more recently, Treasury Board submissions. So really to inject evidence into every stage of the process, and to do so in partnership with patients. So I've got Elise and my many colleagues at the Patient Advisors Network. We have 2 patient partners on every project we do. And as we go forward, it's essential, particularly for the reasons that Jay just described, that engagement of patients in things related to AI are going to be really important. So in the world, the tech world, there's this idea of techno-determinism. If a technology exists, it will be used. Primary care providers don't subscribe to this philosophy. They've spent 20 years resisting the most ubiquitous technologies in clinical care, like email, video conference, use of the phone for clinical visits, or online appointment booking, unless they're adequately compensated, they get the tools for free, or they get some kind of supports. So as a system, we have the choice. We can design what problems we want to solve, what kind of system do we want to enable, and then support the appropriate technologies. They're not just going to run like wildfire. They don't. People need support. They don't naturally take these things up. So as Pyle has outlined, access is really the current problem and everyone seems to want to solve. And so you can look at this problem from the supply side and the demand side. On the supply side, Pyle's outlined the issue of administrative burden, that if we can free up time for doctors from tasks that don't contribute to better patient outcomes, they can then produce more care. So we have a range of tools in this area. And I will say, as a center, the key questions we always ask are, does it work? Does it scale? Does it work at scale? So AI scribes, we've shown, at least on a small scale, they seem to work. We're now working with OMD and Canada Health Infoway to evaluate the implementation of 10,000 AI scribes across Canada to 20% of all primary care providers. So we're going to see what kind of a dent that makes in admin burden, but also what's the impact on documentation, and does it generate data that could then be extracted and used for information sharing. The other things that are, we're interested in seeing are AI inbox managers. So as you may know, one of the big part of admin burden is this avalanche of anyone who works, any knowledge worker is, their day is dominated by email. Well, up until recently, clinicians were protected from this, but now we have very big inbox burdens. And so you now have AI tools that can triage a message to the right place, can prioritize, so you deal with the most urgent stuff first, and even draft responses. When you think of AI scribes, that's actually just essentially ambient listening that turns what you hear into information that can then be used to support clinical decision supports or robotic process automation. So there's a whole suite of potential tools, and we're just beginning to see its potential. On the demand side, when we think about timely access, what it means really is access to triage. Does the person need care in 1 hour, 1 day, one week, or 1 month? And in primary care, as many of you know, it probably could be all of those. People have many issues of varying urgency. And so, in a way, what we hope to do is to shape demand through triage. Now, what tools do we have to shape demand currently? So you have Health 811. Health 811 has a symptom checker called ADA, which is an AI, has some artificial intelligence in it, and it will probably expand over time. It's been tested with vignettes. It's been tested in some, basic ways in clinical encounters, but it's actually rolled out across the province, not only in Ontario, but in many countries. And we don't quite know what it's going to do. Particularly one of the concerns is that it might over-triage. So it might allow people to manage their care better, but it might send more people to seek care elsewhere. So that's your first layer. The next is the medical office assistant, who are the key to triage in much of primary care. And they don't have much in the way of tools to help them. And they've not been the target of AI and decision support, but we're hoping that's coming soon. Nurses are kind of the backbone of triage. They currently do most of it, and there are tools that could replace nurses, but not that many tools that could enhance their work. And again, we hope to see more of that coming forward. So as we try to test these things, we're interested not just in how does one tool work, but how do a set of tools work to solve a set of problems to have an overall impact, so the ecosystem of tools. So with Pyle and Jay and many others, we're interested in building a living lab. So not only that simulation lab that's in the second floor of our hospital, but a network of clinics that are interested in trying this stuff. And we're working with engineers and so forth, and so that's something we're just rolling out. But we want to build it into the policy process so that we say, number one, is this problem worth solving? Number two, is this prototype worth implementing? And number three, is this program you've invested in, does it work? And number four, is this part of an overall strategy that's taking primary care where we want it to go? So, ultimately we want to use AI and various tools to free up clinician time, to automate tedious tasks, to increase human connection. And when we come back to the idea of equity and fairness is excellence, how we distribute our time is really essential. So in primary care, if I can spend 30 seconds or 5 seconds generating an automatic message to a patient that is highly activated, providing a tiny bit of information, and then turn around and spend 45 minutes in person with a frail elderly patient, that's an equitable distribution of resources. And we want to see how we can enable a system that gives people what they need when they need it. Thank you.
Thank you. Thank you to the panel for your valuable insights. Now I'd like to move into the group discussion and dive deeper into the topic. We're running a little bit late, so I'm going to kind of shuffle up for you guys, make it interesting. There are particular challenges to showing that AI is safe and effective. What are your views about evaluating AI?
Sure. So I'll just say on the AI scribe side, what Pyle highlighted, the impact on your administrative burden, the experience of care. So what we don't know is what it does for documentation. Some doctors said, sometimes I don't finish my notes at the end of the day. and then I forget about it, and I realize I never finished that note. And that means not only did you not finish the note, you didn't do the things that you didn't write down in that note that you never finished. So it's possible that AI scribes will raise the floor on documentation, but it might also affect how we think about care, the kind of decisions we make at the end of the day when you're like, oh, I forgot to ask about this, I forgot to do that. Is it going to impede clinical decision-making in ways we can't predict? So our next phase of work is actually to look at notes pre-post. Pre-AI scribe use, post-AI scribe use, and look at the quality of documentation. So that'll be a first example.
The other thing I'll just say that the tricky thing with AI, but also the opportunity, is it moves so fast. When we started the AI Scribe project, there were 6 AI scribes in the country. I think there's now 60. And the problems we had, some of the issues we saw back then have been resolved. There's new things. So the importance of that ongoing evaluation, that embedded evaluation, the learning health system approach, I think, has always been true, but is particularly true with AI, just given how fast it evolves.
Yeah, thanks. And I think there's, in many ways, the tools that we already have available to us for evaluation apply equally well to AI. And I'm referring specifically to the approach that O'Neill and Pyle have referred to, like this embedded approach, sort of evaluating and informing policy in real time. I think that's especially important in this case, because we're also building governance systems for this class of technologies as we evaluate it. In contrast to other conventional medical devices that would be evaluated, with a suite of tools in health technology assessment and are already clearly regulated in a particular way. With these kinds of technologies, we're building those systems as we go. So how we choose to do these evaluations, it matters for the sort of safety and harm prevention and promotion of positive outcomes for patients and for the healthcare system, and also because we're figuring those things out as we go. So from an ethics perspective, I would draw on some very common language in the AI design and computer science community around fairness, accountability, and transparency. So AI also presents an opportunity because it's popularizing those words and those concepts in terms of their importance in this kind of domain. So, how are we thinking about fairness? Because there's fairness in the data, when there's missing data, or as we heard this morning, where some of the data is in Manitoba and some of it is in Ontario, that's an issue. But also, O'Neill has presented a system level view on fairness. Some patients need only 7 minutes and some need 45. So, fairness that's a consideration for fairness as well. Accountability, there's the most responsible provider model, and where there's a human in the loop using these technologies, that's very different than a patient going to ChatGPT and seeking out a diagnosis of some kind. So this is all just to say that we're building this understanding as we do this evaluation, which I think shines a special spotlight on evaluation.
Thank you. Implementing AI in healthcare properly requires collaboration across disciplines and communities. What have you found to be challenging in these collaborations, and what have you found to be rewarding?
Yeah, so I think that's a great question, and I think it's particularly important in primary care. Primary care doesn't have the resources on their own to do this kind of evaluation. They don't have IT people and research people and REB boards. So I think that presented for us a bit of a challenge, but also an opportunity. It meant we had to figure out how to go out into these communities, connect with them, do these broad REBs that really allowed us to sort of get into the clinics. And for primary care in particular, it was really important that we got into that diverse set of clinics and not just sort of the clinics down here that don't always represent the reality across the province. So I think it was very rewarding to do that. You started to, that's where you really saw the benefit, but definitely highlighted some challenges in our system of really being able to do this work well. The other piece I'll just say, this is, we're medicine. There's a lot of other disciplines, engineering in particular, that are great at this. They have tools to understand workflow, integration of digital tools into workflow. So we collaborated with some brilliant engineering researchers led by Dr. Enid Montague at University of Toronto, and I think that collaboration has been critical for us being able to get the kind of data and insights into the tools and their impact on workflow.
One thing I'll say is, integrating this with the policy process and with the implementation process has been really gratifying for me. So we did our study with Ontario MD, and part of it was to compare vendors head to head. And really the goal is to create an AI marketplace where you can vet tools, and then they created standard contracts that were approved by the CMPA, the Canadian CPSO, and the various regulatory bodies to make it easier for doctors to sign on to things. And so it was very easy. I've never gone from an 8-month pilot to 10,000, person implementation across the country. And so being embedded in processes where, we presented this to Michael Hilmer, he's like, this is good, I want to run with this. And then presenting it up to, folks in Health Canada and InfoWay and say, this is amazing, this supports our strategy, and then working with people that can roll it out. So, we always complain about being a country of pilot projects, but I think when the right players are plugged in and you find a solution that makes sense, we can really move things.
On this piece about sort of collaboration and challenges there, the clearest sort of piece of advice or recommendation that I tend to reiterate over the past 7 or 8 years when speaking particularly with vendors about what can I do on Monday morning to make my product more ethical, or to do this work in a more ethical way. The number one response is partner with communities. Of course, abiding by the principles, much of which have been sort of clearly articulated by the Ontario Sports Support Unit, and this community. But engage communities, partner with communities, and do that well. And so that leads into what I see as a challenge, which is around, I'll use the term literacy, AI literacy, but in some ways that's a misnomer around digital health literacy and digital literacy, particularly during the pandemic. There was an attempt to shift toward the idea of readiness to engage, readiness to have conversations. But awareness, knowledge, readiness to engage in dialogue about AI among communities, particularly communities who are structurally marginalized, is really essential. And we all know this, but the curb cut effect, where a curb cut in the sidewalk benefits all parties, not just those who use wheeled mobility, designing for those groups is what will make these technologies work for everyone. So promoting readiness among those communities to engage in design activities, I think, is a unique challenge, and certainly is one that Vasanthi and team is already investing in, which I'll mention a little bit in the next panel. So thank you.
Thank you. Scaling AI across Canada requires a strong understanding of the risks and benefits of AI among patients, which I identify as, healthcare providers, leaders, and policymakers. What do we need to do to boost the understanding, which Jay was kind of talking about, across these groups?
I can start maybe just, in particular with AI scribes. So definitely, with the use of AI scribes, patient consent is part of it. And that was something we talked a lot about, informed consent for patients. And we also talked about, but for, an average family doctor sitting, figuring out how to do a proper consent process, properly inform patients, it's challenging. So as part of this policy work that O'Neill is talking about, the support from government, the central rollout, one of the things we're looking at is how do we create central supports for patients to better understand this AI scribe technology, what it means for their health, how they can make an informed decision if they want it as part of their care, having websites, having pamphlets in offices, QR codes, all of that. So I think that's part of it is, we can't, though, expect individual doctors and small clinics to figure that out. That has to be part of our sort of central, provincial, and overall approach, is how to create those supports for patients and the clinicians caring for them.
As we build out these technologies, this is going to create a level of richness of data, which is amazing for designing systems and balancing, demand and supply in a constrained environment. But it also gives so much transparency or so much information about patients that are going to be held in places and ways that we don't necessarily always understand. And so for me, working closely with patient partners helps us figure out, is this worth it? Are we taking risks? Is this appropriate? Because we can't know what's right, and there's so many competing perspectives here between the vendors, the researchers, the clinicians, the patients, the policymakers. And so we need, fora where often these interests are competing. So where we can manage competing interests and align on a handful of things. So I think that touches on some of what Jay was talking about governance. And as we build out this living lab, we're really thinking about how do we get various perspectives together to manage or at least align competing interests as best we can.
I think we can move along. Couple questions from the audience.
Yes.
We're being pushed along for that,
Yeah,
are
no,
we?
we're being pushed
Okay.
along. All right. Okay, I don't see a question yet. Sorry.
Yeah, whoa, someone's blowing that up really big, that's probably why. There,
Maybe
those
well-
are your questions.
Oh, there they are.
That one
Okay, right there. Read patient empowerment. Patients will gain individual agency with the use of AI tools. Being active in our own health will reduce the burden on scarce primary care resources. How can we launch patient education on using AI for outcomes? Good question.
So this is a great question. One of the things that they say is AI is going to commoditize intelligence. And so as a doctor, I always thought, I'm a good doctor because I'm smart. But pretty soon our patient's going to be just as smart as we are. So now we're going to have to think of what is our value add? How do we partner with people? Because ultimately, it doesn't matter that I'm giving you an evidence-based recommendation in the encounter and then you go off and do whatever you do. What matters is whether we come to an agreement on what's the best thing to do to advance your personal goals and that you go home and do that thing. And so patients executing on the best possible plan, that's not a quality metric, but it will become one. And so the idea that we are in conversation with people, that we build relationships where because I care about you, you're more likely to engage in these things that we've together agreed on are important, that's actually going to be a big thing. I always tell my residents, you got to stay one step ahead of the machine. And what you have is you have your own humanity. So I think here we're going to start sharing power and knowledge with patients in a way we haven't historically and level the playing field. So I think the practice of medicine is going to change. 10 years from now, we're going to be talking about very different things.
Should we take a couple questions and then we can sort of...
Okay. The next question is, considering what happened with 23andMe and its collapse holding masses of private health data, what are your worries and solutions around private organizations providing AI supports to primary care? Good one.
This was I asked this question. No, I think it's so important. It's such a great question, and I think really raises concern about the anti-regulatory, anti-governance movement that we're seeing south of the border right now, because so much of the policy that happens in that country defines how these corporations behave on a global scale. I think here in Canada, I think there's strong awareness of this. In some recent work that I've done on digital health equity in 4 provinces in Canada, some of our respondents talked about their hesitation to come to the table when corporations are also at the table. And I think, that's says something interesting about the value of healthcare as a public good in Canada that we cannot lose. That's really, really important. And also, there would be no AI, there would be no digital health without vendors. And so I think this is something that we need to continue to think about and work on. What do public-private partnerships mean in this day and age? And it's one thing, I've referred to this already, it's one thing when we're talking about AI that qualifies as a medical device, which is like a sort of jargon term that refers to a very specific regulatory pathway that many of you, already know about. But AI Scribe and other AI technologies like it, they don't fall in that pathway. So they're subject to the sort of unusual murky mix of other policy mechanisms that exist in provinces and in Canada as a federation. So sorting that out and what it means for public-private partnerships and building good governance models that protect the public good, I mean, these, I think, point toward immensely important areas of work for the future that will help us to address that for the long term.
Another question from the audience. Might health equity be impaired by patient chatbots, provider scribes, especially for non-Anglo or low literacy communities? How do we mitigate these risks?
So I think one of the things, with the system we have is essentially, because we have access is constrained, it's mostly constrained by geography, knowledge of the system and ability to navigate it, and persistence. So those are the things we filter on right now. So if we break some of those barriers down, we can start to filter on what are people's needs and where do I put my energy? How do I manage my panel? We have lots of patients that suffer at home quietly because they don't know how to get a hold of us, right? So as we break down barriers, there's a risk. I'll just take the example of secure messaging between patients and providers. All your time could be dominated by patients who are super proactive. And then you spend less time on the patients who are less proactive. So AI, I think, will help us with the needle in a haystack problem, which is essentially we don't know who needs something, and we don't prioritize, we don't risk stratify. So now we could have prioritized outreach to people at the greatest risk, as opposed to just wait to see who comes through the door. So my sense is if we are intentional about the use of these tools, we can dramatically increase equity.
Okay, we have one last question I want to ask, but we have very short time. But okay, what about potential barriers using AI with populations who may be distrustful of AI or technology in general, psychosis, homelessness, substance abuse, etc.?
Okay, yeah, I think there's this concept in sort of the ethics literature called structural justified mistrust, justified. And there are communities who do not trust the institutions of healthcare for good reason because of the past and present actions of these institutions. And you can see that this community here is committed to changing that, to enhancing the trustworthiness of the institutions that collect and use these data. So I think the short answer to that question is the long-term work of enhancing the collective trustworthiness of our institutions. And so, yes, there's work that can be done in the clinical encounter to engender trust in the most responsible provider, to say, I'm accountable for this. I think it's a good idea. It will help us do better for your care. But there's also, a longer-term mission here, which is about enhancing the trustworthiness of our healthcare institutions.
I'm going to wrap it up just 2 minutes early so that we can go to break. But I wanted to thank everyone on the panel. Thank you for your wonderful insight, and I learned so much today. And thank you for really kind of discussing this designing and deploying AI tools to address the primary care crisis. Thank you so much.